Good evening, everybody. Welcome to our prevention conference, our monthly series. It's a pleasure to have so many participants, so many people that have engaged in this particular topic. And as you all know, we make a huge effort to bring topics to you that are related to prevention. I always like to thank Anya, who does an amazing job with all the logistics and making this happen. So Anya, as usual, thank you so much. We have another very exciting conference today on a very timely topic. As you all know, I'm Dr. Dennis Goodman. I'm a professor of medicine at NYU in the Department of Integrative Medicine and Cardiology. Next slide. So one of the things I like to do is to tell you how to ask a question. We like to get to your questions. Please go to the Q&A. I think many of you are familiar with Zoom now. And you just click on the Q&A and write your question in at any time during the talk. And I will take the questions, as many as possible, after Eileen's talk. Next slide. So the upcoming lectures, we are taking the usual summer hiatus. It's between June and August. We'll be back in September. And these are the full topics that we're working on: cancer, chemotherapy, and heart disease, diabetes update and your heart health, loneliness, social isolation, and cardiovascular health, and a cholesterol lipid update. Here is the website to register online so that we know about you, and we'll certainly be sending you an email about when the next talk is, and you can register for that, and you can see down there the address. Next slide. So here's our website, here's our email and Twitter. This is all easily available. After this lecture, what we've been doing is putting all the talks onto YouTube, so you can actually get all this information and you will be able to see the talk. So you don't have to write anything down unless you want to. And some people ask for the slides. We don't need to do that either anymore because it's all available on YouTube in a week or two. Next slide. So many of you are regular participants, and I'm very grateful because the series is extremely successful. Sometimes we have over 100 people signing up and listening in. And these are some of the past topics. You can see I've done the truth about tobacco and nicotine replacements, the aspirin controversy, thyroid disease, inflammation in your heart health, CBD oil, cholesterol update. Next slide. Mind, body, heartache, and heart health. And you can see most of these topics are related to prevention. I am a very big believer in prevention. And you've heard me say this many times: wellness is not the absence of disease. You have to be proactive. And every patient I see, I focus on 4 legs for the stool, which is nutrition, exercise and flexibility, stress management, and sleep. That's in the cardiovascular space. But many times I have topics that are related to general medicine and your general health. And tonight's a perfect example. Next slide. Tonight, I am going to welcome and introduce you to Eileen Lydon, who is an adult nurse practitioner in the Department of Rheumatology. She's an expert speaker, and she's been doing this for a long time. She works in the Department of Rheumatology and been there since 2003. She studied nursing at the Malloy College and completed the adult PA program for her MA at NYU. She assists in evaluating hospital consults as well as other outpatient ambulatory care clinics with a variety of autoimmune diseases, including psoriatic arthritis, osteopenia, and osteoporosis. She educates nurses across the nation about osteoporosis and is actively involved in patient education efforts. She works closely with Dr. Honig, who is the director of the Osteoporosis Center at NYU, and she's on the steering committee for rheumatology for advanced providers. Eileen, thank you for joining us tonight. It's an absolute pleasure to have you. We're very proud to have you at NYU, because we at NYU are very lucky that we have experts in every single field. So when I do this series, we always find people from our NYU faculty that can speak to our audience about any area in medicine whatsoever, and they are always experts. So welcome to our expert panel, and thank you for agreeing to talk tonight. I'll hand it to you, and afterwards I'll be asking you some questions. Over to you.
Great. Thank you. Thank you so much. Thank you for that kind introduction. And thank you so much for inviting me. As Dr. Goodman mentioned, yes, I have been here since 2003, but I do work one half day in an osteoporosis clinic with Dr. Honig. I see all types of osteoporosis patients. We prevent osteoporosis and we manage the disease. And I'm in the hospital as well. I see the hip fractures that come in to try to educate the patients on the importance of good bone health and what are the next steps after that to prevent future fractures. So I'm very passionate about it, and I know it's a very big need in today's world, that's for sure. And I'm going to let you know a little bit about that as we go along in this talk. You know, this is going to be a talk about osteoporosis and the importance of good bone health. It's really important that you're able to stay active and do things for as long as you possibly can. The big problem with osteoporosis is that it does not cause symptoms until there is a fracture. And that's why it is critical to have an understanding of how to prevent, treat, manage, so you can continue to move, work, and live your life as fully as you want for as long as you want. And before I get started into the definition of osteoporosis, I just want to mention two conditions: osteoarthritis versus osteoporosis. They sound similar and they often get confused. So osteoarthritis is degeneration of the cartilage in the bones, wear and tear in the bones, and it causes breakdown, versus osteoporosis, which is degeneration of the bones, which is what we're going to talk about today, which does not cause pain. So that I just wanted to, and you can certainly ask me questions at the end as far as that goes. So by definition, osteoporosis, it is a skeletal disorder that's characterized by compromised bone strength, which predisposes one to an increased risk of fracture. Next slide, please. So what is bone strength? Bone strength is a composite of bone density and bone quality. Now, bone density is the amount of bone that you have. It is a T-score that you would get on your bone density when you do get that test. It tells you again how much bone you have, but it does not tell you about the bone quality, which is the microarchitecture. It's how the bone is threaded together. And it really doesn't always give us the whole picture, just getting the bone density, the number there for this reason. So you may have heard of people who have, let's say, osteopenia and they fracture, and people who have osteoporosis and they don't fracture. And this is often because we don't fully understand their microarchitecture. Next slide, please. So this is a slide that looks at a bone under a microscope. On the left is what normal bone looks like. On the right is what osteoporotic bone looks like. So a normal bone, as you can see, there's some small holes and very, very thick struts, okay? Versus the osteoporotic bone, which is very thin, that the struts are barely connected together. This is, if I held that bone on the right in my hand and I let it go, it would crash and break on the floor. And this is really important because patients who have osteoporosis who fracture, they will fracture oftentimes from a standing height or less. So you could just be sitting on a chair, for example, fall over and fracture. Now, if you had that same fall when you were 20 years of age, when the bone looked like what it did on the left, you wouldn't fracture. This is just to show you the fragility of the bone here. Next slide, please. So this is a cartoon that is just showing what's happening with our bone cells. Under normal circumstances, our bone is constantly repairing and replacing itself. In fact, every year, our body replaces 5 to 10% of our skeleton. And every 10 years, our entire skeleton gets replaced. And this is just simply stress on our bones that just needs to be repaired all the time. So there are certain cells, they are called osteoclasts, and they come around and they dig out the old bone, where you could see under resorption here. And then what happens is cells called osteoblasts come into play down below, and they fill up the hole there, and they give us new fresh bone. And this is again what happens in normal times. Next slide, please. So this is a slide of what illustrates what happens in osteoporosis. So again, these cells called osteoclasts come out and they dig up the old bone. And then the osteoblasts come around to put down new bone. But in this case, there is a failure of remodeling. There's a failure of being able to fully fill up that hole there. And this is what can happen when, for example, a woman goes into menopause. So estrogen protects our bones. And then what happens oftentimes is that we are losing bone at a much greater rate than we're actually repairing bone. Next slide, please. So how do we define who has osteoporosis, or how do we diagnose who has osteoporosis? And there is two ways. One is simply having what we call a fragility fracture. As I mentioned before, a type of fracture where one falls from a standing height or less and fractures. So these patients I meet in the hospital that have hip fractures, they just slip on the floor and they fall down. I don't need any more information than that I know that they have osteoporosis. The second way we do diagnose osteoporosis, however, is a T-score on the bone density of a -2.5 or lower. So the lower the number goes, the greater the greater osteoporosis you have, more severe osteoporosis you have. Now, you have heard, as I mentioned before, osteopenia. So osteopenia is a T-score between -1 and -2.5. And that's bone thinning or a precursor to osteoporosis. You're not quite there yet, but you do have some bone thinning. And then a normal T-score is 1 + 1 to -1. So that's considered normal. Next slide, please. So as I mentioned in the very beginning, osteoporosis, we don't know until something happens. So it is called a silent disease. So, you know, we're living our lives, healthy, happy, doing all the things we love, traveling. And then one day, slip on the floor in the kitchen, fall. That same fall you would have had 10, 20 years ago, everything would have been fine. You would have gotten up again. And now you have a hip fracture. You need to go into the hospital, have surgery. And then after that, as far as the rehabilitation, it's hard to know. Some people don't get full independence. And some people do go to nursing homes. And some people do, you know, a lot of people do well and come home again. But it shakes you up out of your core. And it definitely causes people to lack confidence in day-to-day activities that there may be another fracture coming. You know, I'll give you an example. There was a patient I had a few months ago, and her husband were extremely active and extremely athletic. And they had retired and they were going down to the Caribbean in the wintertime, taking trips. And this one time that they went there, they were walking down the stairs off the plane. And on the last step, she tripped, fall, broke her hip. They fly back to NYU to have surgery. And just the shock and the surprise that they had, how could this happen? I was doing everything right. I was taking my supplements and all that. Well, this patient had never had a bone density, had never understood that there's more factors that go into it than just the supplements and exercise, which I will get into moving forward here. Next slide. So this is to describe the incidence of osteoporosis. It's a big problem. Over 53 million Americans have either osteoporosis or low bone mass. This number is expected to rise as baby boomers are getting older and people are living much longer. And the vast majority are women. 80% of the patients who get affected are women. But unfortunately, 50% of every woman over 50 and 25% of any man over 50 will fracture in their lifetime. And this is, as I alluded to before, patients who come in to the hospital, they realize that they lose their independence often after this happens, and some will need assistive devices, canes, some need to go to nursing homes. And then unfortunately, about 25% or so actually will die within the year of having a hip fracture. This is often due to other medical conditions that just don't get treated very well afterwards, but it is a real problem. And even though men suffer fractures less than women, they actually have an increased incidence of dying from this fracture within a year than women do. And in addition, although there's a personal toll, a very big personal toll, there is also a very big economic toll here. This costs about $19 billion in the United States to take care of this disease. Comparing it to other diseases such as congestive heart failure and asthma, if you add up the two of them together, it comes nowhere near to how much it even costs. So just why I'm just bringing home the point of how important it is to share this information. So what we can do to understand and get treatment and prevent fractures. Next slide, please. So here we see the burden of osteoporosis. This is in postmenopausal women compared to other conditions. So you see here, heart attacks, strokes, and breast cancer, the number is much lower than osteoporotic fractures. In fact, if you add up all these three conditions, you still don't get near the 2 million of the osteoporotic fractures now. This is likely because we're doing a much better job at preventing heart attacks, breast cancers. We are getting our mammograms, heart attacks, we're getting our blood pressure, our cholesterol checked, but we're not doing as good of a job as at getting our bone densities and being aware of the treatments that can help prevent the fractures. So this is a problem. And another big problem that I see in the hospital, to have one fracture is one thing, but then to come in and find out that people have had multiple fractures and never started or never been educated on starting treatments to prevent other fractures happens quite a bit. In fact, this morning I saw a woman who had a hip fracture. A year ago, she had her other hip, and then 5 years before that, she had a wrist and hadn't had a bone density or bone strengthening medicine, because within the first year of having a fracture, you have a very high likelihood of having another one. So this is what we try to do to help. Next slide, please. So this is just showing the incidence of all the types of fractures. Now, the most common is vertebral fractures. They can be extremely painful, but also they could be asymptomatic, and it's basically a compression down of the vertebrae that will cause height loss. And again, it is the most common one we have. As I mentioned, hip fractures are also very common. About 15% of women by the age of 80 and 5% of men will have a hip fracture. Wrist fractures are also very common. They tend to occur in younger people because they're often putting their hands out in front of them to stop themselves from falling. Whereas we're getting much older, it's more of a balance issue, and one will fall directly on their hip. And all those, some fractures, other fractures that any other one doesn't require surgery. It still doesn't take away from the fact of how much pain and impaired function that can cause. Next slide, please. So here's a picture of someone who has spinal osteoporosis. You could see the woman on the left She is standing straight and tall. And then over the years, her height has shrunk and she has become hunched over. It's what we call becoming kyphotic. And this is due to the compression of the spine. And this deformity is a permanent deformity. It can cause problems with reaching and bending. Being so hunched over could even cause problems with breathing. And also causes problems with self-esteem. Spinal fractures are a big problem. Once you have one, people often have another and another. So you don't want to miss this. Now, as I mentioned before when I was talking about osteoarthritis, so people can shrink, lose height from osteoarthritis because of the wear and tear. Or from compression fractures. So when we see our patients, we always check their height and we ask them what their peak height was when they were in their 20s or 30s and compare it to their current height. And if they have lost a couple of inches, we will get x-rays of your spine to see if there's any fractures there so that we can treat. Next slide, please. Okay, so now over the next few slides, I'm going to be talking about risk factors. Now, there are some you can control and there are some that you can't. And even there are people that don't have any of these risk factors and it's just purely a genetic problem. But the first one I'll mention is age. So increasing age is one of the biggest factors for osteoporosis. And as I mentioned earlier, women get it much more often than men. And low weight. So one who is 127 pounds or lower has an increased risk of osteoporosis. Having a small frame, maybe not so much padding when you fall could be the reason for that. And then as far as the ethnicity, all ethnicities are at a high risk of osteoporosis. However, African Americans are a bit lower. They're a bit lower when they're younger, but then when they get older, they are actually at the same rate as Caucasians. And family history is really important. If you have a parent, for example, who's had a hip fracture, you do have an increased risk of having a fracture. And then lifestyle factors. And I'm going to be going through these over the next few slides. Next slide, please. And certain medical problems. So working in rheumatology, I see a lot of patients with rheumatoid arthritis. So an overactive immune system does cause lack of calcium in the bones and osteoporosis. Hyperthyroidism. So it would be hyperthyroidism that's not treated. So if that's why it is important to get your thyroid checked all the time and from time to time, shall I say, but that if you need treatment, this is a very important reason. Another condition called hyperparathyroidism. So when your parathyroid gland secretes too much hormone, that can sometimes happen when you don't have enough vitamin D. That can cause osteoporosis. And then gastro conditions such as Crohn's disease, celiac disease, if one had bariatric surgery, for example, conditions where you're not able to absorb proper nutrition, your vitamins, your vitamin D and calcium can definitely increase your risk of osteoporosis. And then some medications. So the most common medication is steroids, prednisone. It's very strongly associated with osteoporosis. And this is not just, a few days of prednisone here and there. This is somebody who has been on it for at least 3 months or greater. Other medications, androgen deprivation therapy, which is used in prostate cancer, aromatase inhibitors, which is used in breast cancer, and anti-seizure medicines. Those are all linked to osteoporosis. Next slide, please. Okay, so now this is getting back to the age as a risk factor. This is a nice slide that shows bone growth and loss over the life cycle. And just to explain that when we are growing up, it is in our early years, it's very important to have proper calcium and be healthy in other ways, because by doing so, then when we reach 20, 25, we reach our peak bone mass. And then when we get to about age 35 or so, we do start slowing down with our losing some bone till about age 50. But then there's a rapid loss, and this is really occurring in women that are going into their postmenopausal years. And then as we age, you can see 60, 70, 80, it just goes lower and lower as we get into more advancing age. And I know I mentioned the estrogen in women being a big problem with rapid loss. Now, this does happen with men too, with loss of testosterone hormone, but it just happens at not as a rapid rate as it does in women. Next slide, please. Okay, so this is a slide that's showing the differences between men and women. As far as women, it really often has to do with the lack of estrogen. And there's just a few different reasons that this can happen besides normal menopause, early menopause, so one that goes into menopause before age 45, for example, one that would get a hysterectomy that also has the ovaries removed at a younger age, anorexia. So this is often associated with, let's say a woman who also is missing their menstrual cycles because of the anorexia, because of the low weight. So the more often you miss your cycles, then you're really doing a lot of potential damage on the growth of your bones, especially in the early years. And multiple births is really important, as well as somebody who's had 8, 10, 12 children. They are pregnant, obviously, then they're breastfeeding, and all those months that they're without their periods, they're really lacking the estrogen there. And then with men, it is often overlooked. It is a myth that men do not get osteoporosis. As I mentioned, about 25% do, and they will suffer mortality at a higher rate than women. Next slide, please. So here are the lifestyle risk factors. So not getting in enough calcium or vitamin D, physical inactivity or immobility. So let's say if you don't move at all, sometimes people, let's say, for example, in the hospital for, they're bedbound for a while, those people will lose bone at a rapid rate. So just simply walking does matter. Excess alcohol abuse, cigarette smoking, and frequent falling. These are all risk factors. Next slide, please. So what can we do to prevent? So throughout the whole life cycle, calcium and vitamin D is critical. Exercise is critical. And I'm going to talk about it in the next few slides a little bit more, but this is weight-bearing type of exercises. Just putting your foot on the ground, just simply walking does help. Things like preventing falls. If you could prevent a fall, then you're going to prevent a fracture, and avoiding excess alcohol and smoking. And doing this throughout your entire life cycle, no matter what, you will be doing a great deal of good for your bones. Next slide, please. Okay, so what is it? How much calcium, vitamin D, what are we talking about here? So we are saying to get about 1,200 milligrams of calcium in your diet every day. We say that you should get this from foods as much as you can. So you want to start looking at labels if you're not doing so already. Milk, for example, is about 300 milligrams of calcium. So is yogurt. You look at, cheese Keep in mind that green leafy vegetables have calcium, almonds have calcium. And if for some reason you're not able to get 1,200 milligrams a day, you can take 1 tablet of a calcium supplement. That's perfectly fine. But we say not to take more than that. And this is simply because our bodies really aren't designed to break down more than 300 or 400 milligrams of the calcium supplement. And you actually can increase your risk for kidney stones. So the next is vitamin D. So vitamin D is critical. If you have a low vitamin D, you're not actually able to absorb calcium into your bones at an adequate level. So vitamin D is sometimes even a bit more important. Our goal is to get you to a level of around 30 to 50. So this is something when you go to your provider, ask from time to have your vitamin D level checked, so that you can get the appropriate amount of supplement. And it does vary. Sometimes we give higher doses, sometimes we give lower doses, but we keep checking our patients to make sure that they're at the adequate level. And because, you know, vitamin D is hard to get in your diet. It's not like calcium. You can get it in egg yolks, cod oil, and obviously from the sunlight. But we don't get sun all year round. You need about 10 minutes of sunlight every day. However, you know, you're also supposed to be using your sunscreen. So we're not saying to avoid sunscreen at all. And I find that the majority of the patients, and myself included, have low vitamin D. It's hard. So taking the supplements, and the supplements do work, is very important. So the next for prevention is the weight-bearing, muscle strengthening exercises. So again, every day for about 30 minutes, just simply walking would be good. It gives a little bit of increase of your very, very tiny bit of increase on your bone density and your bone tissue by doing some kind of exercise, just weight-bearing kind of exercise. But as I said before, by doing nothing at all, you're going to lose bones. That's why it's very important. So doing that, you could, you know, jogging, dancing, climbing stairs, anything where your foot's based on the floor. Then a couple of times a week, do some muscle strengthening exercises. So building some muscle around your bones is really important. And this is important, you know, especially as we age and balance issues come into play. You go to fall, that you're able to catch yourself, that you're strong. And with that, balance. So if there's any issues with balance training should be part of your exercise routine. And Tai Chi in particular has been studied for balance and to help reduce the risk of falls in osteoporosis. So smoking about a pack a day, you could lose about 5% of your bone mass. So we discourage this always. And alcohol, 3 drinks or more a day is not good for the bones. Never mind that you do have an increased risk of falling when you do take in too much alcohol. And then reduction of risks of falling. This is huge, 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 because again, if we could prevent falls, oftentimes we can prevent fractures. So making sure that your home is safe as it can be, making sure your room is well lit, that there's not loose rugs on the floor, that there's enough handle railings around when you get up, that you have the proper assistive devices if you need a cane, a walker. These things are critical. Getting your eyes checked, making sure you can see, making sure you can hear. You know, and if you need some physical therapy or balance training, it's really important to get plugged in with, you know, ask your provider to go to physical therapy that's specific for that. Next slide, please. So screening. So bone density is the most reliable method that we have, right, to diagnose. And there is some recommendations. So any woman who's 65 years or older should be routinely screened, as well as a man, 70 or above. You should have your baseline bone density by that age. Now, you would need to have it done at a younger age, 50 or above, if you have any other risk factors. So let's just say you went into menopause at an early age, or you had a fracture already. These are reasons to have a bone density at a younger age. Next slide, please. So this is what the bone density machine looks like. It's painless. It is really easy to do. You lie on a table for less than 20 minutes. Often it only takes 10 minutes. And what they're looking at here is they're looking at the amount of bone you have in your spine as well as your hips. It has very low amounts of radiation. It would be about the same as, even less than if you went for a regular x-ray, or let's just say you're taking a trip across the country. It's about that same amount of radiation. Next slide, please. So now we're getting into when do we treat, how do we treat, what goes into it. So it's not a one size fits all for how we decide, but this is a calculator that really does help guide us. So what we do here is a lot of the risk factors that I talked about, we will put it into this calculator and then it'll come up with a score. And if you have 3% hip fracture or 20% major osteoporotic fracture, what is that telling us? It's telling us that in 10 years' time, you have that risk of having a fracture. So having, let's say, a 3% risk of having a hip fracture in 10 years. So this helps us decide when we want to start treating somebody to reduce the likelihood of them having a fracture at that time. So things that we do put into this calculator, well, first we're going to look at the height and the weight, the gender, if you've had a previous fracture before, if your parent has had a fracture, if you're a current smoker, if you take prednisone glucocorticoids, and again, that's if you're taking it for 3 months or greater, 5 milligrams a day or greater for 3 months, if you have the condition rheumatoid arthritis, if you have secondary osteoporosis. So secondary osteoporosis are things like hyperthyroidism, premature menopause, for example. So some other conditions that we're looking for there. And alcohol, so drinking 3 or more drinks a day. And then what we do is we take the T-score on your bone density on your hip and we plug it in there. And then this is how we get the calculation. Now, this is great as far as gives us an idea for the hip, but you'll see there's nothing there about the spine. And so this does not give us good information for that. However, these days, some of the bone density machines have some software on it that it's called a TBS score that looks at the microarchitecture of the spine. So in those instances, when we have that information, we can plug that in there. That gives us a very accurate picture of what your risk would be in 10 years' time. Next slide. Okay, so this slide is showing you all the medications that we have available. So again, these are medicines that actually will strengthen your bones. They will slow down the bone loss process. When I was showing you earlier that slide with that cartoon of losing more bone at a greater rate of repairing it, well, that's what a lot of these medicines are geared to do. So we have bisphosphonates. So those are medicines like alendronate, risedronate, zoledronic acid, which you may have heard of. Then we have estrogen therapy, hormone replacement therapy. This is often provided by the GYN doctors. We have relaxifin, which is a selective estrogen receptor modulator. So it focuses purely on the bone and has low side effects of the other estrogen therapies. Then we have a tissue-selective estrogen complex called DuoB, and this is similar to relaxafen. And this is also, it is monitored and prescribed by the GYN. The rank ligand inhibitor, denosumab, is another. And then finally, our strongest medications are the anabolic medications, teriparatide, abaloparatide, and most recently, romosozumab has been on the market. So the ones that we use most often are the bisphosphonates, denosumab, and the anabolic medications, but we do use and see them all. You know, the bisphosphonates, you can take them orally, or the one that's IV is the zoledronic acid. It's also known as reclassed. That's once a year. And it often, you know, people do like that option. It's an IV over half an hour. About 15 to 20% will get a flu-like illness. So we ask that you take Tylenol or Aleve before that. The oral bisphosphonates have to be taken on an empty stomach first thing in the morning because of any kind of regurgitation that goes up to the esophagus that causes some pain. That's for that reason. So you take it on an empty stomach and drink with a full glass of water and sit upright once a week or once a month sometimes. Then I'll move down to the denosumab. So that's a subcutaneous injection that's given once every 6 months. It slows down that process similar to the bisphosphonates of how much bone you're losing compared to how much you're gaining. It slows that down. So it is a very nice drug as well. The one thing that we're learning about it is that you can have some rebound bone loss if you don't take it on time. So it's very important when you're getting this medicine that you do get it every 6 months, because it has been associated with some vertebral fractures if it goes beyond that time frame. And the anabolic medications, so teriparatide and abaloparatide, these actually, as well as the romosozumab, they actually build bone, but the teriparatide and abaloparatide, these are daily injections that it's like a pen that you would inject yourself every day, and you can give this medicine for up to 2 years. And then the romosozumab, it is an injection. It's a once a month injection that is given for 1 year. And I'm sure there'll be some questions here on the medication. So I think I'm gonna end there with, next slide, please. Okay, thank you. Next slide. Okay, next slide. Okay.
Hi, okay. Eileen, thank you so much. That was wonderful. I've had so many questions already. I just want to say that I could have changed this topic to don't take your heart for granted, because what you said is so appropriate to cardiovascular disease as well. It's silent until there's something happens. And there's unfortunately that, you know, close to 50% of heart attacks where people die, it's their first and last symptom.
Yeah.
So it's the same story about being aware that you could have osteoporosis. And most people find out about it when they have a fall and they have a fracture.
Right.
So the point you're making is find out about whether you're at risk from a fracture before it happens.
That's right.
I read a statistic that, you know, people over 65 who land up in hospital with a hip fracture, unfortunately, up to 20–25% of them die within a year.
Right.
Now, obviously, that's because many of them are over 85 or over 80. And as you point out, they have complications related to the hip fracture. So they land up, they've got to have surgery, they have complications with pneumonia, and it can land up being ultimately the cause of their death. So I just want you to comment on this specific question. What is your recommendation for bone scan, DEXA scans? You said 65. Should it be done every year, even if it's normal? And what about men? Should they have a DEXA scan?
Right. So yeah, every 2 years is how often one should have a bone density in both men and women. Now, if we start seeing a trend where it's significant osteoporosis, we may do it on an annual basis. This is often, though, insurance dictated how often we can get the bone densities. If somebody is on medication, we often try to get bone densities on an annual basis to see, how well the medicine is working. But with that said, that is sometimes more individualized as well. But in general, every 2 years for screening and just monitoring.
What percentage of women over 65 do you think that you see an abnormal scan, either osteopenia or osteoporosis?
Wow, I would say, oh my gosh, like 85%, at least some degree of osteopenia. I am not at that age seeing completely normal bone densities.
Yeah, so it's so prevalent that you have to do something about it. So I've got a lot of questions about medications. And as you pointed out, there's so many options. And I think a lot of people go to a doctor and then there are all these options about what you take. I know a lot of people that come to me, they're on Prolia and they're worried about side effects. For example, this jaw necrosis thing, which people worry about because they read about it. And my understanding is it's very uncommon. So would you just mention, I think it's denosumab, right? Prolia, because that's quite a common one. How often do you turn to that as a first-line agent? And could you just give us a little guideline as when are you using these agents versus just trying to be preventative with supplements, calcium, vitamin D? Does it depend on the severity of the DEXA scan?
So when we decide to treat, is not just the number of the DEXA scan, it's looking at all the risk factors. We're using this FRAX as a guide often to help us. So, a lot of times, maybe years ago, people were being treated at a much younger age just based on their bone density number. But these days we try to, look at each individual person's risk factor, certainly before we start. Now, as far as what medication we start first, that's also very individualized. It depends on how high your fracture risk is. So for example, if you have a bone density, let's say of -3.5 or greater, and you're 60 years old, we're gonna go right to the anabolic agents that actually build bone. If you have a lower bone density, at a younger age, then bisphosphonates or Prolia would be one, that we would use. Now, as far as the rare side effects of osteonecrosis of the jaw, it can be in, both Prolia as well as the bisphosphonates. It's extremely rare. But what we do is if we're about to start somebody on these medicines and they need to get a dental implant or a tooth extraction, we will hold the medicine, before getting started. But if they need that and they are on the medicines, we continue it and we just say use like an antibiotic mouth rinse to move forward. So that's how we take care of that.
Okay, let's take some of the questions. Have studies been performed on the long-term use of osteoporosis medications?
So most of them are about 2 to 3 years. The longest one we have is with Prolia. That's about 10 years out. That was actually just approved in 2010.
Okay.
Yeah.
How many years can you stay on xylendroic acid infusions?
So that's an example of the other rare side effect, the atypical femur fracture. So that's why with the bisphosphonates, we try to give what we call a drug holiday after so many cycles. Zoledronic acid, we will, after 3 cycles of the drug, reevaluate. And if we can give a drug holiday, obviously this depends on how severe the osteoporosis is. Zoledronic acid can be given annually, every 18 months or every 24 months. So like I said, we wait 3 cycles. Okay.
Next slide, Anya. What are the side effects of synthroid levothyroxine? Should it be discontinued after a certain amount of time? So that, does in some ways relate to to osteoporosis. But do you have an opinion about that?
Taking Synthroid is great. It would be great, as long as you're getting your thyroid functions monitored, because not treating, so if you're hyperthyroid, as I mentioned, untreated hyperthyroid, then that you could run into trouble with osteoporosis. So taking your medicine appropriately and getting your thyroid TSH-T3, monitored so that you have the right dose is the most important. But right. You would have to necessarily discontinue it.
So there's a question about side effects. Like any medication, if you take too much, you can get side effects. There are side effects, cardiovascular side effects, if you take too much thyroid medication, like palpitations and fast heart rate, high blood pressure. So it's really important to have your thyroid functions monitored and to be closely followed by your doctor when you take these medications. Should I take Prolia? Of course, I mentioned this before and you touched on it. How do you answer that in 2 sentences? I think the answer is see your doctor, see Dr. Honig, and you'll decide. But do you want to guide this person just on when would you reach for Prolia?
So, definitely every provider would be, thinking of it a little different, and everybody individualized. I just want to make sure I point that out. Sometimes with this medicine, we'll wait till somebody's a little bit older, but it doesn't always have to be that way. So we have 10-year data on it. So that's where we are right now with how long, we feel comfortable patients staying on it, but it looks very good. It's just it's hard to say absolute, because every situation is an individual situation, but we use it. We use it a lot. It's just the most important thing is staying on it every 6 months, not missing that dose because of the rebound, bone loss and the spinal fractures that it can cause.
Okay. I've got a lot of questions about the type of exercise you should be doing. How important is it to do like power walking versus just like, walking, and should you be lifting light weights? Is there any difference in terms of trying to prevent osteoporosis? There was a question about a biodensity machine. It's all based on the same idea that we're doing something to give your bones some kind of impact, because that's how they build. You build bone when you have impact. That's why things like swimming are not as good for your bones as walking and jogging. Is that true?
Right. Yeah. Anything that you can put your foot on the ground, weight-bearing exercises is good. There's not, running isn't necessarily better than walking. Walking is good enough to just build up that tissue, even minimally, but it does something. Yes.
Yeah. So I just want to make the point. Exercise is so important for your cardiovascular system, but it's very, very important for your bones as well.
That's right.
Next slide. How many years can one stay on zoledronic acid infusions? We mentioned that. How about PRP? Platelet-rich plasma. You could just mention that, and is that helpful for osteoporosis? And just tell people what that is.
Yeah, we don't have data on that. So there's no data that supports that it slows down osteoporosis. It's spun down out of your blood sample. It's your platelets that come out of that, and for certain bone conditions, sometimes it is given to help from, but there is no data that it slows down osteoporosis.
Exactly. I think some people use it for arthritis or things like that, but when there is actually disease there, but I haven't seen any data that it prevents osteoporosis. Let's go to something that is a lot of questions about supplements. So you mentioned vitamin D, and I think it's crucial that people know what their vitamin D levels is, just like you know what your cholesterol is, because that's another risk factor. So you mentioned this, and I just want to reinforce it. It's very easy to get a vitamin D level. You should ask for a vitamin D 125 hydroxy vitamin D level. It can be measured. Every time you see your doctor, you should ask about your vitamin D level. It certainly once a year should be measured. And we give vitamin D based on what that level is. You mentioned you like to see a level above 30. I like to see it like 40 to 50. And then I like to prescribe or advise people to take vitamin D3. And depending on the level, I use between 1,000 and 5,000 units of international units of D3 a day. And then I repeat the D level a few weeks later, 3 months later. So I think I can't say enough about how important vitamin D is, and I'm sure you agree with me, because vitamin D increases calcium absorption. That's what its job is. And it also helps to get calcium into the bones. So it's really important to have an adequate vitamin D level. I want to just make this point because people have asked and sent in questions about other supplements. I happen to be a fan of vitamin K2. I actually wrote a book, this is not an advertisement, called Vitamin K2, the Missing Nutrient for Heart and Bone Health, because there is some data that vitamin K2 helps to activate osteocalcin, which is actually produced by osteoblasts. And you need osteocalcin to bind calcium, which is so important for healthy bone. So I know there are some studies. There's some very good studies. There was a study that was in the international, in a Bone International journal in 2013. It was a Dutch study. There were 244 patients. And they showed that people who were supplemented with vitamin K had better bone densities. It's hard to prove that there's less fractures, but you would assume there are. I just wanted to touch on that for you because what are the supplements that people can take? I mean, calcium, vitamin K2, do you believe that these can help? And if someone asks you about them, supplements, what do you actually say to them?
Well, what you just mentioned, the vitamin K2, we are using that. More recently, we've been using that. Calcium, vitamin D. Well, all the other supplements, like people ask about strontium, magnesium, and fluoride sometimes. I mean, we get a lot of different questions, and there really is no data to support that, that we recommend that we don't. Yeah,
so I'm just weighing in that I do think there's enough data for vitamin D and vitamin K2 to at least have a discussion with your doctor about that. Next slide, Anya. So let me just, I think I wanted to ask you one more question. When should people start getting bone scans? I just want to ask DEXA scans in terms of risk factors, because you said it's 65, but like, mammograms, we start at 50. Would you do a DEXA scan in somebody if they've got risk factors?
Yes.
Smoker?
Yes. At age 50 years on, if you have risk factors, yes, you can get a bone density.
Okay.
For those who don't have any risk factors and they wait till 65.
Yeah. So I think to sum up, and I want to thank you. This is such an important topic. Just like heart disease, people don't realize they've got a problem until something bad happens. So I want to urge people to check your vitamin D level and speak to your doctor. All good internists and family physicians will speak to you about your bones and your bone density, and will probably get a DEXA scan, certainly over 50 if you've got risk factors, or 65 as a routine test. And I really thank you for bringing attention to this topic. And I just want to draw to our listeners' attention the fact that we have an outstanding osteoporosis center at NYU. Here's the address on the slide. Here's the phone number if they'd like to make an appointment with you or Dr. Honig. And the number is 212-598-6367. So with that, I'm going to end off and say once again, Anya, thank you very, very much for joining us, all of you. Here's how you contact us, hearthealth@nyulangone.org. And Anya, please will you send an email to everybody about when they can access the YouTube link so that you can watch this lecture. And we have recorded many of our topics so you can access them as well. And we look forward to seeing you all back at the end of the summer. Have a good, healthy, happy summer and be safe. Thank you very much, Eileen.
Thank you. Thank you very much.